So welcome to this video. This video is going to talk about chest x-ray and how to interpret the basic anatomy that you see on a chest x-ray. In the next video, we'll be talking about the different types of pathological conditions associated that you will see on the chest x-ray. So we start off by talking about the modalities used to image the chest. Usually a radiologist would have to pick what is the appropriate method in order to get the right photograph of the chest in order to determine the pathological condition by the patient. Now, a chest x-ray can be done in a posterior. Chest x-ray itself is a modality. Then you have different forms of chest x-ray. You have a PA, which stands for posterior anterior. Then you have a lateral format. Then you have an AP, anterior posterior. This is usually done for patients who are in severe conditions and unable to move. And during this video, we'll go on to show you what an AP, what a PA, what it looks like. An expiratory PA chest. And then we have a lateral decubitus, which is usually when a patient is lying down in a lateral format. CT, MRI, and PET. So just to summarize that, you have chest x-rays, and within chest x-ray you have different formats of chest x-rays. Then you have CT, MRI, and PET. Now, a radiologist usually talks about, when they look at a x-ray or something, they usually talk in different languages and terms. They usually use the term opacity and lucency. Opacity is anything that's usually white on the x-ray, and this can include any soft tissue such as organs, fluid, or bones. Lucent, which means less denser, usually is represented by black, and this represents air in the lungs. So the lungs is usually very lucent because it contains very air. So when the air when there's some sort of pathologic condition, it usually turns opacity, which means it turns white because there might be something in it. Now, hyperlucency, on the other hand, means basically lucent, means air. So hyperlucency means there's too much air in the case of COPD. So keep that in your mind. So opacity means there's some sort of consolidation, or there's some sort of blockage, or there's some sort of, or it can just be the regular soft tissue, fluid, or bones. Lucency can represent air. Usually lucency is represented by black on the x-ray and opacity by white. Now we'll come back to the different image. So PA basically is represented by the top left on the screen. This is when the patient is usually standing with their back facing towards the radiologist or the x-ray technician. So PA basically means posterior to anterior, just indicates the direction of the x-ray passing through the patient. So the x-ray comes in from the back and it goes directly through the back into the front. So, and the film is, you can see the white thing on the where the patient is standing forward and reflects off. A lateral is basically from the lateral side. Now, lateral decubitus is important because this is usually very important in determining free-flowing fluid in the pleural space, so like pleural effusion or something like this. And our AP is usually shown by the guy on the bottom facing forward. So this is when the x-rays come directly forward into the chest, into the heart, and then to the back. Why we usually don't use an AP is because you want to minimize the effect of the heart or the shadow created by the heart or the heart silhouette. But radiologists tend to prefer PA, posterior from the back to the, so posterior to the anterior, and lateral decubitus or lateral in general are the three main ones that radiologists would use. Now on the screen now you have a basic x-ray. Now we've highlighted everything that is just for you to know the basic anatomy. So let's start off with, we have the trachea here, and then behind the trachea we can see the vertebral bodies, and inside the vertebral bodies, if you can see this little white circles, this represents the sphenius process. It's important when to check the vertebral bodies. Usually you should count the number of vertebral bodies up to the point of the clavicle, and usually a solid number would be number 4. So there'll be 1, 2, 3, 4. If anything more or anything less, that means there's some sort of asymmetry or the patient is rotated or something. Now, a rotation is indicated when the spinous process usually should be directly in the middle of the vertebral body, as shown here. If the spinous process is slightly tilted to the side, that means the patient is usually rotated, and that can determine whether the image is good quality, or it can affect the other parts that you look at. So start off by looking at the trachea, then the vertebral bodies, and check if the spinous processes are directly in the middle. Now you can see the heart here, and you can see the left ventricle highlighted, and then you can see the right ventricle. You can also see on the bottom here the diaphragm, or known as the hemidiaphragms, and then we have the left costophrenic angle, which is on the bottom right of your screen, and then you have the right costophrenic angle on the bottom left of your screen. Then we can split all the white stuff that you see are the bones. So we have the clavicle on the top, and then we have the costal ribs, and then we have the hilar region, and then we have the different types of fissures involved. The fissure, we have the horizontal fissure, and then we have the oblique fissure. So on the right, we know that there's 3 lobes. So we have the superior, middle, and inferior lobes, whereas on the left, there's only, you can split it into 2 lobes, but radiologists, there are different zones and different lobes, and we'll go into it throughout the video. So we have the superior lobe here, and then we have the inferior lobe. Now, the important things are you should always look out for the cardiac notch or the cardiac ankle or the aortic ankle. Some people like to address it different. So in the next one, this is an x-ray of a normal patient. So there's a normal x-ray of a healthy looking patient. So using the stuff on the left, we can identify the trachea. So the trachea or the bronchia, the bronchial region, we can go straight in first, look for the trachea. We can see the trachea is filled with air because air goes through it, so it should appear lucent, i.e. it should appear black. So behind the vertebral bodies, directly behind the spinous process, you can see a black tube coming down, and usually it is split somewhere here around the point of cornea and into the left main bronchus and right main bronchus. And number 2 on your screen should be hilar. The hilar is a region. The hilar region is described as a region where there is arteries, veins, and there's the major bronchi. So this is basically the area, the point of entry of the arteries, veins, and the major bronchi into the lung. Now it's later on in the video we'll go on to see exactly where the hilar is. You are able to see the lungs clearly because it's completely filled with air, so it appears lucent. You can see the hemidiaphragms on the bottom. The edges of the diaphragm is created by the liver, and on the you can see that the right diaphragm is usually more pushed up compared to the left diaphragm, and this is because the liver is pushing it up, and then the explanation for the left to be more down is because the heart is pushing it down. Then you see the heart directly in the middle. The heart is usually, you need to check as a radiologist or as a doctor, you usually need to check the cardiac thoracic ratio. So the heart should be the first you measure the distance across from the costophrenic angle to the left to right or right to left, and usually the width of the heart from the right ventricle to the left ventricle, and it should be no greater than 50%. Then you can see the aortic knuckle, which is where the mouse is clicking right now, and then you should be able to see the ribs, the scapula here at the back with the humerus and the glenoid fossa, as well as the clavicles. Then if it's a female patient, usually the breast is quite visible on the x-ray. Males not so much, but it can be very tiny because they don't usually have breasts. But females, you can see the breasts are indicative, so beware that the breast usually can mask the costophrenic angles, i.e. the angle at the bottom of the diaphragm, or it can block off the whole of the bottom diaphragm space, leading to an unexperienced radiologist to think that it could be some sign of pleural effusion or something like this. So now the important invisible structures are, on an x-ray you are not able to see a sternum, an esophagus, spine, pleura, fissures, or the aorta. Sometimes you can see the fissures, but on a normal x-ray you are not able to distinguish between the different types of fissures. Now, usually on a chest x-ray assessment, what people like to go through is, in my terms, I would usually go through the bronchial region first, then the hilar region, the lung zones and lobes, the costophrenic angles, i.e. the diaphragm, the pleural space, aortic knuckle and the mediastinum, and then the soft tissues and bones. So that leaves us with around 8 things to go through. So start off with the airway, so bronchial, then the hilar region, then the lung zones, then the costophrenic angles, then the pleural space, and then aortic knuckle. So we're going to go through the basic anatomy of these region in the next few minutes, starting off with the bronchial region. Now, on the screen, you can see a bronchogram. So this is not how a usual x-ray would look. So here you can clearly see on the right, you can see the trachea coming down and splitting into the right main bronchus, and then go to secondary bronchus to the upper lobe, secondary bronchus to the middle lobe, and secondary bronchus to the lower lobe, and likewise on the left hand side. So this is not how you would see. This image is obviously fluoroscopied, so it's emphasized for us for our education purposes. Now, so in this you can clearly see, like I mentioned, trachea contains air, so it has to be lucent, so it appears more dark. So behind the spontaneous process and behind the vertebral bodies, you can see, it's not exactly behind, it should be in front, but in this for the x-ray terms, you can see a black shadow going down, 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 and it splits into right and left. So you can see the trachea, and then in this you can see the hilar, and you can see the lungs, the diaphragm. So the trachea should be midline or slightly to the right. If it's usually pushed to the left or more to the right, then there's some sort of pathology involved. Now I've highlighted exactly how the trachea is, so we can go back and see. So the blue line should represent it coming down. The cornea is a point of differentiation to the left and right, and then it splits into the right main bronchus and left main bronchus. So now visualize the blue line when you go back to the previous. So you can see that it comes down and then into the right and then into the left. So deviated trachea usually indicates pathology. Always has to be centrally located, and it can be slightly shifted to the right. Now the hilar region. The hilar region, basically, like I mentioned before, it consists of the major bronchi, pulmonary veins, and artery, and is a very good indication. Always look for visible hilar regions. Hilar regions also consist of lymph nodes. So lymph nodes can usually mask the effect, but usually you will not see the lymph nodes. Now, what exactly is a hilar region? So on this diagram, you can see the lung, and you can see the pulmonary trunk going in from. So you can see the superior vena cava draining into the right atrium, and the inferior vena cava, which then supplies the right ventricle, pumped out through the pulmonary trunk into the right pulmonary arteries, and then basically the pulmonary veins brings it back into the left atrium. So the junction between the right main bronchus, the right pulmonary arteries, and the right pulmonary veins all together, the point where all of these enters the lung together, is known as the hilar region. Same with the left. So on this screen you can see, so let's first find the trachea, i.e. the lucent black thing that's going down near the spinous process down. So now you can see it's splitting left, right, and then left. So now you've got your right main bronchus giving off a branch. Here we don't exactly know whether this is a bronchi or whether this is the pulmonary artery or anything. So what usually when it goes in here, this whole white thing. So now the black bit represents the right main bronchus because there's air in it. The white things that's coming down, like I said, is opacity. It contains fluids because a blood vessel usually has a fluid, i.e. blood inside it. It would turn more white, and it's a soft tissue, right? So this region here altogether is known as the hilar region because it consists of both the right main bronchus, the pulmonary arteries, and the right pulmonary veins going back into the atrium, into the left atrium. So this is known as the right hilar region, and again coming down from the trachea into the left main bronchus, and you can see all these white things are basically blood innervations, blood supply. So this whole region is known as the left hilar region. So I've highlighted it on the right side of the screen as what I would say is the right pulmonary artery, giving off the different innervation, different blood supply to different lobes. So this one will go to the upper lobe, middle lobe, lower lobe, and likewise. Now, the yellow indicates basically the bronchial tree, and then the red indicates on the right indicates the blood supply. So you can see the left hilar is usually higher than the right. So the hilar region is basically a collection or a point or a junction where arteries, veins, and bronchioles come together into the thing. And usually pathology is associated with this area because blockage of this area could mean, or elevated pressure, blood pressure or something could usually cause this area to become more greater in density or in size. So as a radiologist, you should always look for the size, the shape, and the density of the area. Now, each hilum contains major bronchi, so you know all of this. A normal hilar position. By convention, the hilar points are the angle formed by the descending upper lobe veins as they cross behind the lower lobe arteries. Not every abnormal patient has a very clear hilar point, so don't be afraid if you can't see a hilar point, but if they're present, they can be useful in determining the position of the hilar. So when you see something, when you see a regular x-ray and you see next to the heart a white region, that is not an indication of pathology. It can be consolidation or pneumonia or something, but we will discuss that in the next video. Usually it's just the hilar region. Next is the different lung zones. So in this video, I would like to split the right lung zone. Usually some radiologists like to split the lungs into different three or four different zones, the upper, middle, and lower. But for this purposes, we're not going to split it into. All we're going to do is split into right upper lobe, middle lobe, and then the right lower lobe. And left upper lobe, the lingua, which is basically the area that surrounds the left border of the left ventricle, and the middle lobe surrounds the right border. So anything that's close to the right border, right ventricle, is known as the middle lobe, and the left ventricle is known as the lingula, and more towards the end is known as the left lower lobe. So from a lateral side of view, the right lung is very important because it is not exactly how we see it. So we have a superior lobe, middle lobe, and inferior lobe with the horizontal fissure and then the oblique fissure. So you can't really, like I said before, you are not on a normal x-ray, you will not be able to visualize the fissures unless there is some sort of problem, because the fissure itself is covered in the visceral pleura. So if there's some sort of pleural effusion or thickening of the pleura, then you can visualize it. So on this screen you can see we've indicated on the left here is the right lobe, right lung. So you personally know that the right lung has 3 lobes. So the upper lobe here, this is the horizontal fissure, and this would be the middle lobe because I said it's more closer to the right ventricle. Now, a silhouette sign is usually used by radiologists to determine. Silhouette sign basically means loss of contour between 2 objects. Usually in a normal x-ray you can differentiate between the edges of the lung and the heart, but when there's a silhouette sign, i.e. loss of contour, the heart shadow usually merges in with the hilar region shadows, so you can't really see the edge of the heart. So this is a silhouette sign, i.e. loss of contour. So there is a pathology involved here, or there's some sort of pleural effusion here in this one. That I'm not describing this x-ray, but I can see 2 or 3 pathological conditions involved here. The next thing you should look for is a costophrenic angles. The costophrenic angles usually are the bottom formed by the hemidiaphragms. So a costophrenic angle is usually very sharp, and what's highlighted as blue, the lines, are known as the costophrenic recess. This area is important to look for because a loss in shape or blunting, i.e. blunting means the edge, as you can see on the screen, the red line is drawn in a sharp knife format, like a knife, very sharp. When it becomes blunted, it usually becomes more curved, forming a meniscus. That can usually indicate a sign of pleural effusion. Another one, but sometimes it can be mistaken when a woman's breast or something is too large. It can cover this area, leading to make you think that there is blunting and there is pleural effusion, but sometimes it's just simply the breast covering it. Or another one in COPD or something is when there's hyperexpansion of the lung, i.e. there'll be more It'll be hyperlucent. There'll be more air in the edge, causing it to look more blunt. So these are all trap holes to get you caught. Now, pleural space is important. Usually, a pleural space, you know, the pleural cavity of the lung. There's a visceral pleural and there's a parietal pleural. The visceral pleural covers the lung, whereas a parietal is more towards the edge. Now, usually, this area is very important because a pleural space is an area where there can be tension pneumothorax. So tension pneumothorax is when there's air in between the pleural cavity. If there's fluid, then it's known as a pleural effusion. If there's any sort of pus or anything, it's known as an empyema. Now you start off by usually with the right lobe, so you go down and then you follow the edges of the lung and then you look around. If there's something wrong with the pleural space, there'll be two lines when there'll be a black or white shadow inside it, which we'll talk about in the next video. So the diaphragm is very important because the right diaphragm is usually higher than the left. If it's pushed down, it can be due to a pneumothorax or a pleural effusion or air trapping in the lung, such as emphysema or asthma, or a consolidation in the case of a pneumonia. If it's pushed up, it can be due to liver enlargement, ascites, splenomegaly, hernia, or air in the colon, such as the transverse or the hepatic flexure or the splenic flexure of the colon. In the pleural space, if there's air or something trapped inside it, this could be due to pneumothorax. If you see any abnormalities in the pleural space, that it could be due to pleural effusion or empyema or hemothorax, which is basically blood inside the pleural cavity. So remember that the pleural space is kept under a tension and under a negative pressure. So the pleural has a negative pressure, so it stops the lung from collapsing. So the moment you have air or something in it, that negative pressure becomes more positive, meaning that the lungs are about to collapse. So that sums up the whole video. So hopefully, in just a review, you should be